Hello, everyone. My name is Alyssa, and I want to thank you for joining me on the Pressure Injuries webinar. I have worked in long-term care now for 5 years as a nurse. Currently, I am an MDS coordinator and assistant director of quality insurance, and I had the desire to increase education about pressure injuries because of the implications it has for the patient, for our institutions. There are a lot of risks associated with it, and also because I realized when I became a nurse that I didn't get a lot of information about pressure injuries in nursing school. A lot of what I learned was stuff that I had learned on the job, fortunately, from the nurse practitioner that I work with, who is phenomenal. So I decided, that I wanted to be able to educate my fellow nurses about pressure injuries, how they form, some of the risks and complications associated with them, and also why they are so detrimental to the patient. So thanks again for joining me today, and let's go ahead and get started. Before we get started, I have a housekeeping item. I have no financial relationships to disclose with any of the organizations discussed in this presentation or with the Ohio Nurses Association. I have no conflicts of interest to disclose, and I will not be discussing commercial products or services. I will discuss classifications of products that may be appropriate interventions for pressure injuries, but I will not be discussing specific brands or brand names when discussing those specific products. So what are pressure injuries? Pressure injuries, formerly called pressure ulcers, are areas of tissue death and damage resulting from prolonged pressure to an area of the skin. They occur more commonly in frail populations, namely those who are mobile, malnourished, or individuals with perfusion issues, and also individuals who are incontinent. The prolonged pressure to the area leads to ischemia, cell damage, and eventually cell death. Commonly, these are also called bed sores or decubitus ulcers or decube ulcers. They have since been renamed officially as pressure injuries according to the National Pressure Ulcer Advisory Panel. This was something that was decided a couple years ago. I know probably some facilities still, I know mine sometimes, what's used in charting is still pressure ulcers, but for the purpose of this CE, we're going to be referring to them as pressure injuries since that is the official terminology now. So, risks and complications. Patients who develop pressure injuries are at a greater risk for localized infections to the wound and also systemic infections, aka sepsis. Infections, and especially sepsis, can increase risk of death for these patients who are usually already frail and ill. Pressure injuries can also be quite painful for patients, and pain can have negative physical and emotional impacts for the patient and their caregivers and family. Just think an acutely ill patient who develops a pressure injury is going to require more of your time, and they're going to have a longer stay due to this new complication. Let's talk about cost. Healthcare costs in America are higher than other developed countries. We all know that. Not that money is the main driver, but we all know that healthcare costs are important to the patient, the places we work, and the system at large. Not to mention the human cost, things that cannot be quantified, like loss of ability and life. So we know prevention is key. Preventing a pressure injury costs less than treating one. It is estimated that the cost to heal a pressure injury is anywhere from $20,000 to $150,000 per patient, depending on the severity. Higher stage pressure injuries can take months to heal. Just to give you an example, I had a patient who came to our facility in the skilled unit with what started as an unstageable pressure injury, and we'll get into what that means in a little while. When the wound bed had cleared, it was a stage 4 injury, which means it was all the way to her bone. And this was on her sacral area. She was on IV antibiotics, had a wound vac, and visits to a special wound center. After about 6 months, she was fully healed. So 6 months of her skilled nursing stay, which then became a long-term care stay, and all those costs, and then the pressure injury on top of that. The average nursing home costs about $225 per day, or close to $7,000 a month. Avoiding pressure injuries from developing can save the patient and the organization a lot of time and money, and the patient avoids the possibility of unnecessary negative outcomes. So what causes pressure injuries? Well, pressure injuries are caused from just that, pressure. When an area has pressure to it for an extended period of time and tissue death occurs, you have a pressure injury. Friction and shear from moving patients in linens, lines, tubes, and restraints also contribute to pressure injuries development. They are commonly found on bony prominences, such as the sacrum and coccyx, hips, elbows, and heels. They can also be found in areas where tubes and lines lie, such as behind the ears from oxygen tubing or on legs from catheters. Additionally, pressure injuries can develop under immobilizers, braces, and splints. It's important to inspect skin often and move or loosen these as you are able. Lines and tubes can often be padded to prevent pressure. It's best to reduce the sources of potential pressure, but that may not always be feasible in the critically ill patient. So you want to make sure that you are redistributing the pressure as frequently as is feasible, and making sure to check their skin and do very good skin examination each shift. Pressure injuries can develop pretty quickly. I've seen them develop within a shift on a patient who was end of life. So you really want to be very, very cautious. Anytime that you're adding any sort of lines or tubes, restraints, anything like that, you want to think that, not only do you have other assessments you need to do, so like say, for example, if you start an IV, you have to do all of your assessments for infection, making sure that the IV remains patent, making sure that the dressing remains clean and dry. But you also want to think that there's a possibility that even just the adapter that is sticking out of that person's hand or antecubital space, wherever the IV is, can be causing extra pressure on their skin, and pressure injuries can develop because of that IV. So, bony prominences. I want to talk about some of the common sites for skin breakdown. The coccyx, buttocks, sacrum, and heels are very common sites of skin breakdown, and for pressure injuries to develop. The top image shows common sites for patients who are supine. The middle one shows common sites for patients who are laying on their side. And the bottom image shows common sites for patients who are sitting. I like these three images because they show the bones that are underneath, and show the area of impingement. So keep in mind, these aren't the only places where pressure injuries can develop. These are just pretty common areas. So you want to be especially careful in patients who maybe are underweight or malnourished, and have less cushion, so to speak, in between the bone and the outer layer of their skin. They're going to be at an even higher risk, because if they don't have that sub-Q layer in between that's kind of helping to give it some cushion, they're going to be at a much higher risk of developing a pressure injury. Particularly, I'd say to the coccyx and the heels are really the areas that I see the most frequently. So some comorbidities of pressure injuries. They are most common in the elderly patient and also those who are immobile. And we also know, obviously, that as we age, we're more likely to have mobility issues, either due to pain or due to fractures, surgery. There's a lot of different reasons. Um, this is also true for patients who are permanently um, impaired with their mobility, such as patients who maybe are paralyzed, or patients who have neurologic disorders like multiple sclerosis. Um, so really, patient anytime someone has mobility issues, whether acute or chronic, you want to be, concerned about their skin integrity. So even patients in surgery need protection from pressure injury development. I'm sure if there are any nurses listening in the audience that have worked in surgery, there are special precautions that need to be taken for patients who are going to go into surgery because they're going to be immobile for a period of time, especially for long surgeries. Different surfaces that need to be laid on the table. The patient needs to be moved. Their skin needs to be checked. Patients who have hemi or paraplegia are at a much higher risk of pressure injury development if they also have decreased sensation to the affected area. So, you want to think about your patients who have had strokes, especially if they, really can't, they have complete loss of anything with that affected area. If they're really just a flaccid um, hemi or paraplegia, then you really want to, be concerned about their skin. And also, like spinal cord injuries, any patients that have their limbs or part of their body affected. Also, patients with impaired perfusion related to cardiovascular changes are at risk as well, especially those who have edema. So you want to think of your PVD, PAD, even your heart failure patients who are having edema that's developing. You want to be concerned about their skin. Um, any changes in perfusion will increase the risk of blood not reaching critical points on the body to prevent ischemia. Some more comorbidities. In regards to weight, patients who are overweight and patients who are underweight are both at risk for developing pressure injuries. Quality of the patient's dietary intake matters as well. It's important for the patient to have adequate hydration and intake of vitamin C, zinc, and protein. Patients who are anemic are at an increased risk due to decreased oxygen-carrying hemoglobin. Smoking also increases risk because it impairs circulation and causes decreased nutrient absorption. Bowel and or bladder incontinence increases risk as well. Individuals who are even occasionally incontinent of bladder or bowel have an increased risk of pressure injury development. So let's talk about some components of your assessment that will be important. When assessing a patient's skin breakdown risk, there are quite a few factors to be considered. Using scales with predetermined questions can be helpful and are quick to use at the bedside. We will explore more of these in the following slides. Of course, no tool is perfect. Always use your nursing judgment when determining what plan is most appropriate for pressure ulcer prevention in all patients. Some of the scales that you might be familiar with are specifically the Braden probably is one that we're most familiar with. There's also the Waterlow scale and the Norton scale. We'll get into the details about those. Things to consider when assessing someone's risk are the patient's mobility, moisture frequency of the skin in question, meaning how often is the skin moist, the patient's sensory perception. So, someone who had a stroke or has neuropathy might be at an increased risk. And the patient's nutrition intake and hydration are also very important. Patients who are on TPN are typically considered to, have inadequate nutrition, even though it's pretty controlled what they're getting. It's not the same as if they were able to get a wide, a varied, healthy diet by mouth. So that's something to keep in mind. Also, friction and shear, that's something that, kind of goes with mobility. If the person is, unable to reposition themselves in the bed and staff is having to reposition them, you want to be cautious about the way that you do that to reduce the amount of friction and shear that they might be experiencing. So here we have the Braden scale, and many of you are probably familiar with the Braden scale. It focuses on 6 domains to determine risk: sensory perception, moisture, activity, mobility, nutrition, and friction and shear. It's pretty quick to use at the bedside, and it gives the nurse varying levels of risk: mild, moderate, severe. And this is considered to be the best tool that we have at this point in time. It's pretty widely used in different settings. I know I use it in long-term care, and I know that in my clinical position, teaching, the students use it regardless of whatever site they're at. This is, the standard right now. If you look at the different domains here, the patient is graded on a scale 1 through 4, with the exception of friction and shear, which is 1 through 3. 4 being the best and 1 being the worst. So obviously with the scale, having a lower score is going to mean a higher risk. So this one we have here is the Norton scale. I skipped over the Waterlow scale. It's kind of just an in-between between the Norton and the Braden. The Norton scale is the original tool from 1962, was when it was formulated. And it's not used very often anymore, but it's the basis for most of the scales that are used today, including the Braden. So the purpose of having it here is more for historical context than anything. It focuses on 5 domains: physical condition, mental condition, activity, mobility, and incontinence. And it does not take nutrition into account. So obviously, between 1962 and the introduction of the Braden scale, it was determined that nutrition clearly needed to be added. And that's why it's now included in the Braden scale. This one works pretty similarly. The higher the number, the lower the risk. Low number equals high risk, and it looks pretty much at a lot of the same stuff, 1 through 4, for pretty much everything. And it's, pretty obvious how this is the basis for the Braden scale. So I wanted to include this scale that I personally have not used, but I had heard of it and found it in my, research of doing this CE. So it's called the CYPUS scale, and it is specifically for patients with spinal cord injuries. So anyone that works in neuro maybe has seen this. And it has a lot more items than the Braden or the Norton, obviously, including lab results, autonomic dysreflexia, living setting. So this is something that can be translated not just in the acute care setting, but obviously can be used, in a home setting too, and out in the community to determine what kind of risk the patient has for development of pressure injuries. And I think, it kind of gives a lot of the same information as the Braden scale. I mean, looking at albumin obviously is looking at someone's dietary intake in a way, their overall nutrition. But, there's more emphasis here on perfusion issues. Um, Tobacco use is taken into consideration, cardiac disease, renal disease. So it just kind of goes a lot more in depth. And for this one, the higher the number, the higher the risk, which is the opposite of the other ones that we had been looking at in the previous two slides. So I really like this tool. I came across this before in school, actually, when I was at the University of Akron, and had saw this for a project that I was doing. It's called a skin bundle tool, and it's a bedside assessment tool. It basically, what the nurse does is calculates a daily Waterlow score, which, like I said, is a scale that was an improvement on the Norton scale, but not quite to the degree of the Braden. And then it has different interventions and a checklist to monitor compliance. So this particular one is from the National Health Service in the United Kingdom in conjunction with the National Pressure Ulcer Advisory Panel and the European Pressure Ulcer Advisory Panel. According to them, bundling is now considered the most appropriate method for pressure ulcer prevention. That's also according to the Institute for Health Improvement. And bundling was actually featured in American Nurse Today. I have not personally ever seen... I've seen, with different charting that it might suggest different interventions. It might have, prompts for care planning and different things when you start documenting that a patient has a skin injury or a pressure injury. Or if, you're documenting that they're at risk. I've seen some of those triggers in different EMR software, but never really seen anything quite like this in any setting where I've been. But I would be curious, if anybody who's in the CE has seen something like this or used something like this in the setting where they work, if they feel like it works better than just, kind of going with whatever interventions, are available. If, having this guidance really helps, I think that would be very interesting to know. To me, I think it makes a lot of sense. I would like to have suggestions if I have a new admit and I can get a score on them, and then it gives me suggestions for what to do to prevent them from breaking down in the first place. I think that would be very useful. So, yeah, if anybody has ever used one of these, I'd be curious to know how they felt about it. So let's talk about some prevention strategies that we could use for our patients once we've determined that they are at risk. You want to implement these as soon as feasible. Obviously, if you have a patient who's critically ill, you're going to focus on what's more acute of an issue than their skin, but at the same time, once they've been stabilized, then these are things that you're going to want to implement as soon as possible. So we're going to go over each of these strategies individually. One note to add that doesn't require a separate slide is that areas of risk for skin breakdown should not be massaged. Massaging at-risk areas can cause tissue destruction and initiate the inflammatory process, especially in the elderly. So if someone is complaining of pain to, say, their heels, you wouldn't want to massage that area. You would want to make sure that you offload pressure, because if you massage it, while it might seem nice for the patient and they might think it feels better, is actually putting them at a higher risk of skin breakdown. What does the research say? So I'm sure we've all heard about the Q2 hour turn schedule. Many hospitals and facilities still use it today. Unfortunately, this schedule isn't based in evidence, and there's much disagreement about which turn schedule is best. For this reason, the NPUAP recommends patients be turned due to individual needs. The Q2 hour schedule isn't a bad place to start, though, and certainly isn't harmful. Some patients may need repositioned every hour, while others may need only repositioned every 4. What is important with repositioning is that it doesn't put the patient on another bony prominence. For example, you wouldn't want to turn a patient from supine to their side on a 90-degree angle, because that's just putting pressure on their hip and knee. 30-degree angles are recommended by the National Pressure Ulcer Advisory Panel. Make sure you are encouraging frequent movement and repositioning for any bedbound patient or chairbound patient. Encourage them to get up and walk, even short distances, to alleviate pressure from bony prominences. Friction and shear. So you want to do everything that you can to reduce friction and shear. That'll help to reduce the development of pressure injuries as well. When you're moving patients, you want to be careful to lift them properly and not slide their skin across bed surfaces. Using smoother silk-like fabrics for bedding and pads rather than cotton fabrics can also help reduce friction and shear. Be cautious when dressing patients, removing gait belts, restraints, and support devices, and don't rub too hard when cleansing skin. You want to also, as you're able to, use mechanical lifts to lift patients. If you have a patient who is difficult to move, requires several people, it might be a better idea to use a mechanical lift to move them up in bed rather than to slide them, just to prevent that friction and shear. Continence. Moisture and continence management is especially important for prevention of pressure injuries. If patients are incontinent, frequent checks should be done to keep skin clean and dry, but not too dry. Ideally, skin should be cleansed immediately after an incontinent episode with a pH balance cleanser. Now, I know that's not always realistic, so you can implement scheduled check-in changes for patients that are completely incontinent. You can do toileting programs to train bladder and bowels to prevent incontinence in the first place. If the patient is mobile or their cognition is such that they're able to let you know, then you certainly want to make sure that they're being toileted pretty quickly. For some patients, it might be appropriate to insert a catheter or a rectal tube if continence is really difficult to manage and pressure injuries are stage 3 or greater. We'll get into staging a little bit later. In addition to continence, you want to monitor other sources of moisture that can cause problems, such as sweat, mucus, drainage, and underneath dressings, restraints, braces, splints, and other devices. Especially pay attention to skin fold areas. Those can end up being not necessarily sources of pressure, but you can end up having other skin problems because of moisture there. Think about, for like abdominal folds, under breasts, you can get, yeast, you can have irritation and areas of skin breakdown that aren't necessarily caused by pressure, but regardless, you want to make sure that you're managing moisture appropriately to prevent any sort of skin breakdown. I know I said in the previous slide that you want to keep the skin dry, but not too dry. So for pressure injury prevention, balance between moist and dry is key. If you apply too much or the wrong ointment, it can make the area too moist, which only increases risk for skin breakdown. Too dry and the skin is at risk for peeling and cracking. Apply a mild moisturizer that won't irritate the area. These ointments are used for prevention of skin breakdown and shouldn't be applied to open skin. So you certainly don't want to be applying an ointment if you find that a patient has an existing pressure injury that is open, where the skin, there is an actual visible wound bed. Then you certainly don't want to be putting ointment on that. The use of chemical debridement and other treatments for open wounds will be discussed in another slide. I won't discuss specific ointments because it's going to be different regardless, depending on where you work. But it's important to note that dimethyl sulfoxide, or DMSO cream, is not recommended for the prevention of pressure injuries. It's not approved for human use in the United States, but it might be used in other countries. So I did want to mention it here because that was something that I saw that was a warning when I was doing my research. So use your judgment with the application of the ointment, the same as you would with the administration of any medication. Obviously, if you, are going to implement orders, because you have standing orders at your facility, you want to make sure that they're still appropriate for what stage of pressure injury the patient has. Okay, so let's talk about dressings. Sometimes prophylactic dressings can be used. Depending on your department and institution, the dressings will vary, just depending on which specific brand you use or style, but as far as guidelines from the NPUAP, they recommend polyurethane foam dressings for prophylactic application to bony prominences and areas of friction and shear. So think about if you have a patient who is going to be, they're a high risk for a pressure injury, and they're going to be going into surgery, and they're going to be laying supine, it's probably a good idea to implement a prophylactic dressing to their coccyx sacral area. But of course, this will vary between institutions, and you would still want to then check the skin still, because um, you don't want to create a situation where the prophylactic dressing is actually causing more pressure. So if you determine that a preventive dressing is appropriate, then make sure to take care with application and removal so you don't create any tape tears or irritation from adhesives. Don't apply dressings to areas where they will only serve to hold in moisture against the skin or prevent the skin from receiving proper air circulation to allow evaporation of sweat and other natural secretions. And you also want to make sure you check skin daily, change dressings at appropriate intervals, at least daily, unless it's a dressing that is meant to be on for multiple days, and especially if they become moist, loosed, damaged, or soiled. And make sure the dressing is the correct size for the area. I have found many times, dressings that are excessively large for a small area, and that's just a waste of resources. But I've also found dressings that are way too small for an area, and it's not even covering the full wound bed, or the adhesive part is on part of the wound bed. So you want to make sure that, if you need to cut dressings to make it more appropriate size, or if you need to get a bigger dressing, that you are doing so. Surfaces. So there are various surfaces, such as low air loss mattresses, that have been shown to be effective in preventing pressure injuries as well. Choosing a surface will depend upon the patient's needs and what your organization's policies are. Foam-based surfaces are the most commonly used, but are not always the best choice. There are also powered beds and mattresses that redistribute pressure, and some that even identify areas of high pressure to alleviate it. Of course, one intervention isn't enough, so don't become dependent on offloading surfaces and forget to reposition patients. I won't get into different brands and specific surfaces because what you use will depend on where you work. I've included here, and it will be included with the other materials, an algorithm from the Wound, Ostomy, and Continence Nurses organization that helps deciding which surface is most appropriate for your patient. So, there's going to be a variety to choose from. Mattresses that you have to change out the whole mattress, overlays, or even sometimes just specific cushions that go in the chair, or might just go, immediately underneath the area of concern to offload it. But whatever is deemed to be appropriate by your institution is what you should use. However, there are resources available to figure out which type of surface is most appropriate, even if you don't have the same brand or the exact same thing. It will at least guide you on what type of surface is most appropriate. Nutrition is a very important part of pressure injury prevention, and there are some things to consider for individuals who are at high risk. First, is the patient independent with feeding and taking fluids? When they're eating, do they eat enough protein, vitamin C, and zinc? Those are going to be the three main things that are going to be important for skin integrity. Is their caloric intake adequate? These are questions a registered dietitian can help answer. You want to make sure that the dietitian is included in formulating a patient-centered nutrition plan. They can determine if supplements are necessary. For patients who are having difficulty with oral intake or NPO, they might need supplements in addition to what they're already getting from their meals. Parenteral fluids and protein, vitamins, and minerals may be indicated for patients who have severe deficiencies or later stage wounds. And renal function should also be assessed to determine what appropriate levels of protein are for that individual patient. So, clearly this can quickly become kind of difficult to manage if you have a patient who doesn't have adequate protein intake, but maybe, has poor renal function as well, and they have a later stage wound. So you want them to be getting enough protein to heal that wound, but you don't want to further impair their renal function, which is why it's important to have that interdisciplinary approach to make sure that everyone's input is considered when making a plan for the patient. So now we will get into kind of the meat of the CE with assessment for treatment of pressure injuries. So if the patient does have a pressure injury, you will need to assess the injury and determine what is an appropriate intervention. The push tool is great for assessing and tracking injuries as they heal. It includes assessment data for surface area, exudate, and tissue type, and will give you a score. You will need to measure the wound length, width, and depth, measure length from head to toe, and width from side to side. The surface area will be determined by the longest part of the wound bed times the widest part of the wound bed. And always measure in centimeters and do not guess. Use the same method each time you measure the wound. So we're going to get into some anatomy next. Okay, call back to A&P. A refresher on anatomy. So recall that the skin has the epidermis, which is the outermost layer made of epithelial cells. The dermis lies below it, and this is where all of our sweat glands, hair follicles, blood vessels, and nerve cells lie. Below that is the hypodermis, which is made of connective tissue and fatty tissue. I want to take a moment to give a special note about skin pigment. So something that's super important to keep in mind is that, especially at beginning stages, stage 1 pressure injuries and suspected deep tissue injuries, they might look differently in folks who have darker pigment skin. It's very important to do a good assessment. The problem is assessments that work well on lightly pigmented individuals do not work well on darkly pigmented individuals. So let's explore some skin assessment techniques specifically for individuals with darker skin pigments. The American Nurses Association offers some great information about color awareness for nurses and how to provide the best care for patients. There's a tendency for healthcare providers to want to be colorblind, but really that isn't going to lead to better health outcomes. What is best is to be color aware and understand that patients with darker pigmented skin have different needs and assessment tools that you will have to utilize. One of the first assessment tools nurses use for individuals with lighter pigmented skin will be to see if the skin blanches, testing the blood flow in return. Typically, one presses on the skin in question, and the skin will return lighter, and then blood will return to the area if the skin has good blood flow. If it doesn't, that indicates an area of possible damage. For individuals with darker pigmented skin, this test will not work. So look for areas of induration, bogginess, or even hyperpigmentation rather than redness. If in the course of an assessment you aren't sure if an area is a cause for concern or perhaps is just a normal variation for that person, ask. For areas the patient may not be able to observe, such as coccyx or buttocks, you can ask caregivers familiar with the patient or family, of course with the patient's permission. Unfortunately, because skin assessment is different for individuals with darker pigmented skin, injuries are often underreported or missed until the damage is worse. Utilizing color awareness techniques for skin assessments can help to improve patient outcomes and prevent worsening of existing or at-risk areas. And another thing to note is that in some areas, for individuals with darker pigmented skin, their skin may appear darker naturally, where the skin is thicker. So, in areas like creases, on the coccyx, the skin may just appear darker there naturally. So you'll want to make sure that you are, talking to the patient, talking to caregivers, and really doing a good assessment to feel the skin more so than actually observing the skin, because it isn't always going to look different than the skin tone that you're seeing, but there might be a problem underneath of that area. Let's talk about staging of pressure injuries. So here's a quick diagram that shows the differences between the stages, and we'll go more into detail about assessment of the different stages and what is common treatment in the following slides. So just a quick note that we have stages 1 through 4, we have unstageable, and we have suspected deep tissue injury. Those are going to be the different categories that you could be assigning to an area of concern. For stage 1 pressure injuries, the skin is still closed, but injury has begun. The skin will present as reddened in individuals with lighter skin tone, or possibly darker than the surrounding skin in individuals with darker skin tones. That's known as hyperpigmentation. Other possible assessment items to use for darker pigmented skin would be induration or hardness, bogginess or the skin feels mushy, edema, and changes in skin temperature. The skin may be initially warmer than the surrounding area because of inflammation, but later may become cooler due to lack of blood flow. The area may be painful to the patient. Stage 1 pressure injuries are the beginning of tissue damage. So this is really the best, if something was unable to be prevented or if someone came to you with a stage 1, this is really where you want to implement interventions now before this becomes problematic. So here's an image that shows the difference between blanchable and non-blanchable. This will be a common assessment piece when determining stage 1 pressure injuries in light pigmented individuals. When skin is blanchable, it means that you can push on the area and it loses the redness. This means that the area needs to be offloaded, but damage to the tissue has not yet occurred. Non-blanchable means that the redness does not change when you press on the skin. This means that this is a stage 1 pressure injury. For stage 1 pressure injuries, offloading should always be an intervention. Turn frequency varies by patient need. While the 2-hour turn schedule isn't based on evidence, it's not a bad place to start. If the patient's condition worsens, they may need to be turned more frequently. Manage incontinence and moisture and apply barrier ointment as indicated. Dressing may be appropriate at this stage, but not always. You can use the algorithm to determine which surfaces may be appropriate or follow protocol specific to your institution. Cleanse the area with normal saline or potable water prior to applying any ointments or dressings. Stage 2 injuries are also called partial thickness skin loss. When an injury advances to stage 2, it advances into the epidermis and or the dermis. It could also appear as a blister. So if you find that a patient has an area of concern that you think is caused by pressure and it looks like a blister, then that would be categorized as a stage 2. The wound bed should be red, and there may be minimal drainage. It will usually be shiny if there's moisture, but sometimes it might be dry, but you shouldn't have any slough. Do not accidentally categorize tape burns, dermatitis, skin tears, or maceration as stage 2 injuries. Some interventions for stage 2 injuries, offloading and moisture management, again, are important in healing. Surfaces may be utilized as appropriate. You want to cleanse the wound with normal saline or potable water prior to applying dressings. At this point, hydrogel and hydrocolloid dressings are appropriate for stage 2 injuries, and usually that should only be implemented though if there's little to no drainage. Most of the time with a stage 2 injury, you're not going to have very much drainage, but it is possible. Those dressings can be applied as secondary dressings as well, and they are good for painful injuries. Foam dressings may also be used for stage 2 injuries and can also be applied as a secondary dressing. Honey impregnated dressings may be used for stage 2 injuries if indicated. Specific types of and brands of dressings will vary based upon your institution. So it's really best if there's guidelines for where you work to use what you're going to use, then follow those. But at least this gives you some general information about what is appropriate for stage 2 injuries. So this is the push tool from the NPUAP, and this can be used at the bedside to determine the push score, which translates into pressure injury severity. Calculating the push score can help to track wound healing. So you want to measure the length and width, and that gives you your surface area, the exudate amount, so how much drainage does this wound have, and then the tissue type, and we'll talk about each of those and what they mean. And that will give you, all three of those subscores will give you your total score, and the total score indicates the severity of the wound. So a higher score is going to be wounds that have a lot of drainage, larger surface area, have slough or necrotic tissue, that eschar that we talked about, or we're going to talk about rather in the coming slides. And so those are going to be the injuries that are going to be of the most concern. So here we have the various types of tissue described, and we'll talk about slough and eschar in later slides when we talk about unstageable injuries. For now, let's talk about some of the differences between these, though. Eschar is going to be necrotic tissue. It's going to appear black, brown, tan. We'll go more in depth later. Slough is going to usually be yellow or white, and so eschar and slough are going to be things that are in the wound bed that are, adhering to the wound. Don't confuse them though with, bone, or think that, the injury is, there's something in the wound bed that needs to be removed. These are things that develop as part of the body essentially trying to protect and heal itself. Granulation tissue will be pink or beefy red tissue with a shiny, moist, granular appearance. So this is, as the pressure injury is healing, that's what the skin is going to look like. Epithelial tissue for superficial ulcers will be new pink or shiny tissue that grows in from the edges or as islands on the ulcer surface. And finally, closed or resurfaced, the wound is completely covered with new epithelial tissue, so it's going to be completely covered with new skin. So I'd like to cover two terms before we continue. Slough and eschar are present in unstageable pressure injuries. They will be in the wound bed. Slough is yellow, green, tan, gray, or white, and can be stringy, thick or thin, or mucinous. Eschar may be black, brown, or tan, and is typically hard. If the eschar is on the heels and is hard and stable, you should leave it in place. This is a natural defense developed by the body to cover the wound bed and prevent infection. Eschar may be debrided if indicated, either via surgical or sharp debridement, or with autolytic or chemical debridement. Once the wound bed is visualized, the injury can be staged. These injuries will most likely be stage 3 or 4 once the bed is visualized. It's going to be rare that you're going to have a stage 2 when that wound bed is finally visualized. Stage 3 injuries are also called full thickness skin loss, and they extend further into the dermis and into the hypodermis or subcutaneous tissue. No muscle, bone, or tendon is visible at this point in time, but subcutaneous fat may be visible. There may be some slough, but a stage 3 ulcer can be determined if the slough does not obscure the wound bed. Stage 3 injuries can be shallow or deep, depending on the anatomical location. So for example, in areas where there's no subcutaneous tissue, such as the bridge of the nose, ears, malleolus, and occiput, they will be shallow. Conversely, areas with more adipose tissue may result in very deep stage 3 injuries. There may be anywhere from minimal to heavy drainage. Interventions for stage 3 injuries, again, offloading, nutrition, is going to be even more important at this stage. Moisture management, appropriate surfaces, and cleansing the wound bed before applying any dressings. At this point in time, you're going to be using some different things because you're going to be applying directly to that wound bed, and you're going to want to focus on managing drainage. A lot of times these wounds will have some form of drainage, so alginate dressings are appropriate for wounds that have moderate to heavy drainage. And be sure to change dressings as frequently as the amount of drainage requires. Heavy draining wounds will require more frequent changes. Oftentimes, alginates will be applied directly to the wound bed, and then they'll have a foam, hydrocolloid, or transparent dressing applied over them. Transparent dressings are appropriate for dressings that can stay in place for a longer period of time, or for wounds requiring autolytic debridement, which we will discuss in later slides. Collagen matrix dressings are appropriate for non-healing stage 3 wounds. Negative pressure treatment, or wound vacs, may also be appropriate for heavily draining stage 3 wounds. Foams are placed in the wound bed, and a suction tube is placed over the foam. The system is sealed with a transparent dressing, and there is a drainage collecting system that moves the drainage out of the wound and allows it to heal. These typically stay on for days at a time, but may need changed if soiled. And you also want to make sure when having wound vacs that you're not obstructing the system, you're not obstructing its ability to create that negative pressure. So let's talk about epibole, undermining, and tunneling. Epibole and undermining typically occur with stage 3 and 4 injuries. Epibole occurs when the edges of the wound bed curl under themselves because the wound is too dry. The solution is to make sure that the wound bed is kept moist enough. Undermining occurs when the wound extends under the edges of the wound bed in multiple directions. Tunneling occurs when the wound extends under the edges of the wound bed in one direction. To assess this, you will need to insert a probe gently into that space parallel to the wound bed until you meet resistance. Measure the amount of undermining around the wound and describe location using the face of a clock. For example, 2 centimeters of undermining at 6 o'clock, 3 centimeters of undermining at 12 o'clock. Packing alginate or similar dressings into the area of tunneling or undermining to absorb drainage will aid in healing. You want to make sure that when, it's not always going to be obvious looking at the wound from the outside that undermining or tunneling is occurring. So you want to make sure that you assess for that and that the dressing is getting appropriately placed and you're packing into those areas, because if you don't put something in those spaces, then it's not going to heal properly. It's just going to have, pockets where there's just drainage that's staying there. And it's not actually, keeping the wound bed clean and keeping the moisture appropriate for healing. Stage 4 injuries are also called full thickness tissue loss. They will have muscle, tendon, or bone directly visible or palpable. The depth of these injuries will vary based on location, just like with stage 3 injuries. Because they often extend to the bone, osteomyelitis is a big concern. There may be slough in the wound bed, but not enough to obscure it and prevent staging. As mentioned previously, these injuries can and often do have undermining or tunneling. Drainage may be anywhere from minimal to heavy. Sometimes it's difficult to think about, but I mean, it's really this, if you have a stage 4 injury, I mean, that's, pretty problematic for the patient, for it to extend all the way to the muscle or tendon or bone. And, it's almost unnerving a little bit, I think, sometimes to see, an open wound where you can actually visualize someone's bone. I know we all have seen, different things caring for patients, but, these injuries usually look pretty uncomfortable, and typically they are pretty uncomfortable. So interventions for stage 4 um, includes all of the interventions we mentioned for stage 3 injuries. Stage 4 injuries may also require surgical interventions, and dressings to prevent infection may be considered. So we'll talk about that, in later slides. But it's going to be a lot of the same stuff that we talked about. Your alginate in the wound bed, foams, honey impregnated, covered with, you know, the hydrocolloid or transparent wound vacs. And if you have a lot of drainage, having that negative pressure system might be a good thing to help treat that wound. But obviously, still offloading nutrition is again going to be really, really big. Um, it's important to make sure that they're getting adequate protein, because these wounds can really take quite a while to heal, depending on the severity and the person's overall well-being and all of their different comorbidities. For patients with severe pressure injuries, surgery may be an appropriate intervention. Surgical intervention may include flap closure of the wound bed or perhaps skin grafts as well. Once the pressure injury is closed by surgery, it is now considered a surgical wound and should be treated as such. The area will be at risk of skin breakdown still, and interventions will still include offloading, nutrition, appropriate dressings, surfaces, and cleansing. Surgical intervention is usually implemented for non-healing stage 3 or 4 injuries, and it is not considered to be a first line of, intervention. This is going to be for something, that the patient has had the injury and other things have been tried and are, it's really not healing well. Or it could be used for an area where the skin, maybe the pressure injury is healing, but the skin itself is really not healing in a good way. And so maybe a skin graft is appropriate for appropriate closure of that area. So unstageable wounds. They're going to be at least stage 3 or 4, but the wound bed is not able to be visualized because of slough or eschar in the wound bed. So we already covered what those are, but wound beds with these will need special treatment. Slough and eschar may be debrided surgically by sharp debridement at the bedside with a scalpel, or with the aid of dressings or medicated creams that will help to debride the area. Collagenase enzymatic ointments may be applied to the slough or eschar under a dressing, but should only be applied to the area with eschar or slough. You don't want to apply to the surrounding skin because it can damage healthy healing tissue. So, suspected deep tissue injuries, also called deep tissue pressure injuries, will typically appear black, blue, maroon, or purple, or they might even look like a blood-filled blister. The injury is deep, but the depth is unknown. That's why it's suspected. The skin usually appears to be intact, but it might feel indurated or boggy, might be cooler or warmer than the surrounding skin, depending on the damage. These are not able to be staged. They might appear hyperpigmented in darker pigmented individuals and are usually pretty difficult to detect visually. So that's where, the touching the skin is going to be really important and feeling that area. The injury may develop further, and eschar may appear, or it might become open and stageable. Treatment for these injuries includes keeping the exterior moist, offloading, and nutrition and hydration. So what can be done? With most patients, having at least one or more risk factor for pressure injury development might seem daunting to figure out what interventions are most appropriate for your patient. Prevention is the most important thing, though. Preventing pressure injuries from developing in the first place will save the patient discomfort, reduce the amount of time spent in the hospital. In patients that do develop injuries, or the ones who arrive with them, early intervention is important. Make sure the interventions are appropriate for the patient, and they can change over time as the injury changes. Communicating and developing a plan of care that is driven by the patient's wishes and preferences will help ensure that the whole team is on the same page. Educating family and caregivers about continued prevention and treatment as the patient may move into a different setting will also help to keep care consistent across the continuum. And you want to make sure too, when doing education with the family or caregivers, that you're explaining why the specific interventions being used are the most appropriate. Um, you're going to have folks that are going to want to try other remedies and different things like that. But ensuring that what is being done for the pressure injury is most appropriate, and then making sure that the necessary supplies can be obtained. If someone's going home with a pressure injury and you're doing education with a family member on making doing the dressing changes and keeping the wound clean and everything, you want to make sure that you're letting the social worker or whoever is coordinating homegoing supplies know that wounds care supplies need to be ordered and that those things need to be available to the patient and their family. um, Wound care supplies at drugstores can be pretty expensive. So that's not something that you want to be putting on the family or caregivers, at home, because then if they have to purchase those things and they aren't coming through, insurance or whatever, then it might end up, causing them not to treat the wound properly, and then it doesn't heal appropriately, and then the patient ends up back in the hospital or has a worse outcome. So we're all aware that pressure injuries have many complications. Part of quality measures for most hospitals and for all nursing homes is pressure injury incidents, specifically those acquired in-house. This affects not only the patient's quality of life, but affects reimbursement and the public's perception of a facility. Everyone is able to search on Nursing Home Compare through CMS, Centers for Medicare and Medicaid Services, and find out wherever you're working, if you're working in long-term care or also on Hospital Compare, how many pressure injuries were acquired in-house in the past year on your survey. It's measured via the minimum data set, the MDS, and so that is how, those data are collected. And so, it's something that is going to affect the public's perception of that facility. So prevention from nurses at the bedside, it really is critical. There are some situations where there are exceptions, and there's been research trying to find an answer to the question, are all pressure injuries really preventable? We don't yet know the answer to that question. Regardless, prevention and early intervention are very important. Pressure injuries have a huge effect on quality of life. They can be painful, can lead to infection, either localized or systemic. Patients with pressure injuries may require longer hospital stays, or skilled nursing stays, and may take months to heal. The costs associated with pressure injuries can put an undue burden on the patient or provider. You can help prevent pressure injuries and improve quality of patients' lives. I want to thank everyone for attending today. I want to thank also the Ohio Nurses Association for helping me with creating this CE. I hope everyone learned something new. I hope it was enjoyable. I know sometimes some of these topics can get to be a little bit technical, but I hope that everyone was able to learn something they could take with them to their practice, to be able to improve patient care and have a better understanding of skin integrity and the importance of implementing interventions as quickly as possible to prevent or treat pressure injuries. Thank you.